Bismillahirrahmanirrahim. Assalamu alaikum, dear audience. Today, our topic of discussion is about neonatal ophthalmology. Yes, I'm talking about retinopathy of prematurity. Retinopathy of prematurity is one of the leading causes of blindness in children. We have got more and more understanding. We have got more ways to control this disease, but still its pathology understanding is very important. And when we talk about retinopathy of prematurity, today our special focus will be on vitreoretinal interface ambiguities and pseudoretinalization. Because sometimes vitreous mimics as retinal tissue, and this understanding is critical in proper diagnosis and proper intervention. To discuss this aspect, particularly, we have invited Professor Hussein Jiatek from Istanbul University. Professor Hussein has got a professional career spanning over 25 years. He's a vitreoretinal surgeon with special interest in retinopathy of prematurity. He is a member and working currently in Istanbul University, Sarafesa Medical Faculty. He has got 9 patents to his credit. He's a researcher, teacher, mentor, and educator. We are thankful to him that he has accepted our invitation to present his talk in this very challenging aspect, that is pseudoretinalization and vitreoretinal interface abnormalities. Yes, Prof. Please.
Okay. Thank you very much. Okay. Okay, Dr. Ali Mirza, it's really very kind of you to invite me for your conversation. It's my honor to have this conversation with you and with your audience. And it's really very kind of you to introduce me with such a good words, and I'm happy to be here with you. And as you explained in the beginning, you know, retinopathy of prematurity is really a very important issue. I think there's no need to explain the disease, and you know, it's a cessation of maturation process of ROP. Is there a need to explain the stages and zones? I'm not sure, but you know, we start with 4 vessels going temporal and nasal sides. And, you know, is there a need to explain the zones and stages, but diameter with the two times distance from optic disc to macula defines zone 1, and from nasal ora serrata zone 2, and the temporal crescent zone 3. We know the disease goes through stages. At the beginning, it's like this, there's no demarcation line, and this is called as immature vasculature, and there starts a demarcation line which is stage 1, and each goes bulging and reach which is stage 2, and from this reach there occurs some vessels protruding into the vitreous stage 3 fibrovascular disease, and from this there occurs some membranes, and it wants detachment, and this is the plus this is, you know, let's go, everybody knows this. But as I explained in the beginning, and also I was an invited speaker in the World Ophthalmology Congress, in practice I realized that the ROP, in fact, there are 2 types, 2 stages, increasing and decreasing, and like a mirror, both sides of bell curve are really very similar, but we should decide if it is increasing or decreasing. Then there occurs a U-turn, and I can see the mouse. Can you see mouse there? Pointer, can you see the mouse pointer in the screen? I can't.
Anyway. I cannot see, Prof, your mouse pointer over there.
Yes, I can't see as well. Still, okay. Anyway, I can go like this. So, you know, that is the only truth. and we should constantly ask some questions. We know there are two known hypotheses, biphasic and spindle cell, but both hypotheses are different in detail. But finally, both hypotheses goes the same way. And Ali, I can't see you there.
Prof, please proceed. Please proceed, Prof.
Okay, and both hypotheses says the reason behind the problem is ischemic and VEGF, ischemic problem and neovascularization. But if it is neovascularization, then there occurs a problem if ROP is an ischemic neovascular process or if it is an analog of PDR. But if it is like this, and there are so many questions still, those pathogenesis cannot explain. First one about the demarcation line. First, why demarcation line occurs? Those known hypotheses cannot explain. Of course, there is a demarcation line in PDR, but we can see it only by fluorescein angiography. But in ROP, there is a white line at the upper retinal space. And why? What is this white line? What is the reason? And why it is not intraretinal if there's a problem with the vasculature, and even it's visible by ophthalmoscopy. And if the reason is intrauterine and extrauterine condition, why we can see the second demarcation even in the era of anti-VEGF? We can see third, we do injection and the demarcation disappears. And again, so the problem cannot be explained about the conditions with intra and extrauterine conditions. And why the disease goes from stage 1, from stage 2, 3, why the disease is always at the same vitreoretinal place. And while regressing, why does this disease goes and crossing vessels? We know the PDR can never regress in such a way. In PDR, we don't see a crossing vessel. So this is a specific type of regression. And why there occurs a plus disease? Still, those known hypotheses cannot explain. And regarding stage 3, there are so many questions still, those two hypotheses and cannot explain. First and most important one, why, if they are neovascularization, if the disease is about an ischemic retina proliferation, why these proliferations only occurs at the top of stage 2, stage 1 demarcation line? If it is an ischemic problem, then there should be some metastatic neovascularization at the optic nerve head, at the angle, but we don't see anything like this. So why we still claim it is the disease of neovascularization? And also, you can see at this operation, those said to be neovascularizations are extensions of vessels, the retinal vessels. This is a surgery almost 20 years ago that I performed with 20 gauge. You can see, very interesting. You can see this case had a diagnosis of stage 4, but look at this interesting case. Look at me. I will cut off the vasculature, and it is vitreous. Did you see it? The vessel is in the vitreous cavity, and those are all very strange. You can see. Let's go. And if rubeus iridis is no, this is not neovascularization. This is a continuation of iris vessels. See this. In seconds, does an NVI can disappear? No, never, because it's neovascular. But rubeus iridis at ROP can disappear in seconds after sclerotomies, because this is a recanalization. And why, if we leave a very small area without laser treatment, you can see the disease cannot regress. If we close the stage 3 with, excuse me, I should, with laser spots, the disease can disappear. Even you may laser perform, you may perform laser even 90%. If you leave a small area without laser, stage 3, you see it cannot regress. And also, if we perform laser treatment covering only stage 3 area, disease can regress, because during my very crowded schedule, I did this. And also regarding differences in the treatment techniques, excuse me. The rationale between the treatment modalities with PDR and ROP are also different. We know, we do have short time, I think. You know, the treatment modalities, the surgical techniques, if you perform the surgical technique of ROP, cut the membranes and leave the retina detached. If you perform this technique for a diabetic retinopathy, you will lose the eye in days, you know. So also the treatment techniques also says that ROP should be a disease of itself, it's unique disease, and ROP can resemble only itself. Also, depending upon this ischemic theory, the classical modality says that we should perform pan-avascular laser treatment. But if we don't perform laser to hold the retina, then there will be problems. It says something like this. But with my press and cited publication years ago, in my daily practice, I was performing almost 100 cases a day. In short times, I started to perform only covering the stage 3. And you see almost most of the avascular retina is not lasered. It's avascular, but disease can regress. Then these also, all of those questions and answers all points out that the problem is not a generalized retinal problem. Also, this panavascular modality claims that we would perform laser to avascular retina and we would stop the proliferation. But you see that even extending to the lasered area, there are vessels. Even in the laser cases, vessels continue to progress on the avascular area. So there are some important questions. Can you see? My colleagues claims that I perform laser to avascular retina and I will stop vascular proliferation. But you see these pictures. I can't see my pointer, but you see the vessels also continues through the laser area. So there should be something different. And ROP, even in anti-VEGF treatment. I can't see you, Alim. Can I continue? Okay. And also, normal classical hypothesis claims that we would perform laser to avascular area and we would stop the vascular proliferation. But if we really look in detail to the lasered area, normally vasculature continues to grow onto the lasered area as well. So the pathogenesis that's promoted cannot explain very important points of ROP. And anti-VEGF injection treatment. We are the first who published the monotherapy with anti-VEGF, this published. And I think we have short time, and this is exactly real monotherapy. I mean, second injection, third injection without laser. Even at this means Hitler cited this publish. And I go further. I define using binocular ophthalmoscope. Excuse me. Can you see? Can you hear me? And this is my injection technique, and by using binocular indirect ophthalmoscope. And let's go. And look at this. This case is is now 8 years old. And can you see still there are very huge area of peripheral avascular areas. You see, even there is a membrane. I can see my mouse pointer on the left side. You see, so peripheric avascular area is not risky. If this theory was true, there will be problem. See the ages. You can see the date of birth, and and this is angiography, and surgical treatment also has some different issues. Let's go to my pathogenesis. The question, is ROP a generalized problem of retina or localized? Those questions all point out that the ROP should be a localized problem of ROP, of disease. I presented in Euretina years ago, and as I showed you, I started with performing laser to the demarcation line, and it was a very important point. And let's go. And this, my hypothesis was cited in this book as well. You can see my hypothesis was cited in this book, and this, you know, everybody should know himself, the most important point of the world, and knowing yourself and knowing your boundaries, living and limits is criteria of maturity. And human or organism goes maturation by demarcating itself. We all started from the left and go to the right. More mature tissues are more demarcated. From left to right, you see immature, ambiguous, mature, obvious. We know there are some tissues going process of maturation. One of the most important area of the eye is vitreoretinal interface. Vitreoretinal interface in prematurity is really very ambiguous. In this paper, you can see years ago, and you can see the date, and 1991, Archives of Ophthalmology. This electron microscopic study says that in prematurity, vitreoretinal interface so ambiguous that even you cannot discriminate where is internal limiting membrane, where is Müller cells. So what happens? This is my hypothesis. While progressing, this ambiguous vitreoretinal interface, vessel goes and cannot define where is retina, where is vitreous. And internal limiting membrane normally guides the vessels. You know, while we are performing ILM peeling, ILM is covering the vessels. And mature ILM gets very shiny retina. You know, at the immature avascular retina at ROP is very matte appearance. So if the vitreoretinal interface is ambiguous, then the vessel waits, and ILM started to collect at vitreoretinal interface, and this is stage 1. When it collects more, it's stage 3, 2. When it cannot go through the epiretinal surface, then the vessels must turn into the vitreous. And what we see as what is defined as neovascularization, it is not neovascularization. I claim that it is the retinal network that should be at retinal place, but falsely established into the vitreous cavity. And when time gets enough and the ILM cuts off the vessels, ILM matures and cuts off the stage 3. Then it continues, and we see remnant of stage 3. And after a while, the same process may occur after injections. And that is my hypothesis. Vitreoretinal interface ambiguity and ROP is not an ischemic retinal problem. This is what my okay. Vitreoretinal interface waits stage 1, 2, and after a while the vessels turns and grows into the vitreous. When ILM cuts off, matures and cuts off, and this stage 3 goes back and the vessels continues down to the periphery. And this process may occurs several times. And that's my hypothesis, and we can see at this area years later, you can see with, please look at this line. Vessels goes into the vitreous, and this is confirmation of this, but years after. Excuse me, I talked very longer than my expectation. So stage 3 is not neovascularization. It's an aberrant retinal network established into the vitreous. It is a pseudo retinalization of vitreous. It is not neovascularization. And ROP is not a generalized disease of retina. It's not an ischemic neovascular disease of retina. It's not an analog of PDR or any other ischemic retina. So vascular dropout of, if there is an already vessels and we lose it, this is ischemia. This vascular dropout pathogenesis can never be the same of still already avascular immature retina. The main problem at the literature is this: losing already vessels, it should be different than still avascular but never vascular immature retina. So both pathogenesis should be different. Excuse me for my longer than expected talking. It's really very kind of you. That's all.
Well, thank you, Prof. It was something really new and very informative, and I hope it will be very beneficial. But a few things come in the mind. Since decades, we have been following a set pattern about the pathophysiology and pathology of retinopathy of prematurity. Now, this new hypothesis, what is the clinical, from the clinical point of view, when we speak, what is its importance, and why, Prof, do you want it to be accepted widely?
Because if we claim, if we continue to use the older hypothesis, first we must ablate all avascular retina, and in the era of anti-VEGF, if we continue to use the old hypothesis, those hypotheses force us to ablate whole retina, even in the era of anti-VEGF. Even my colleagues in Turkey, and though they sent those premature babies under general anesthesia to fluorescein angiography, and after performing fluorescein angiography, they still forced to ablate whole avascular retina. But I showed years, even at 8 years, avascularity of ROP is not like the avascularity of PDR. They are completely different. They continue this, we should ablate, and it's harmful still for babies. We do mistakes, we do important mistakes if we continue with the older hypothesis.
Prof, while stating that vitreoretinal interface ambiguities is in your hypothesis, and you stated that a similar situation persists in other tissues in eyes, can you please tell us about the other situations where these things can happen?
I think even at conjunctiva, tenon, and sclera. You know, in childhood, while performing a child, there are huge amount of tenon. But in older ages, tenon disappears and conjunctiva goes very tiny. This is my opinion that tenon transforms into sclera, and that's why in older age sclera gets thickened and tenon, and at the conjunctiva, tenon and scleral interface, there is also a transformation, maturation process. And probably there are some other places still we don't know. But maturation is an ongoing and continuing process in whole body.
In your publications on anti-VEGF monotherapy in ROP, Prof, you
Yes.
mentioned the common pathogenesis of ROP and other
Yes.
premature morbidities.
Yes.
Can you please tell us about this as well, Prof?
Yes. For a premature baby, I think there is the common hypothesis, pathogenetic hypothesis for common morbidities of a premature. For head, for chest, and for abdomen. Three main compartments of the body. In the brain, because of vascularization, we see intracranial hemorrhage in premature case. In the eye, because of vascularity of the retina, we see ROP. At the chest, at the lungs, because of vascularity of alveolar maturation, we see bronchopulmonary dysplasia. And because at the abdomen, because of vascularity of intestine, we see necrotizing enterocolitis. During the era of injection, at the neonatal intensive care units, nurses informed me that after your injection, my premature babies goes better, and it was interesting. And we also published this. By using anti-VEGF agents, we made better vascularization of intestine, better vascularization of lung. You probably, if you perform anti-VEGF in your ROP, after injection of ROP injection anti-VEGF, most of the babies lowers the oxygen needs, and they get rid of intubation. And vascular hypothesis, we can explain all main morbidities of a premature case with this vascular hypothesis as well. And anti-VEGF is important.
Well, Prof, it was something really new for us, and your hypothesis is really very interesting. And I hope so it will be something new, and people will focus on it, and it will help them a lot in their future management of ROP. I want to thank you, Prof, for your time. I know you're very busy with your schedule and management, but I'm thank you for you on the behalf of my audience, international, YouTube, and WhatsApp group. Thank you, Prof.
It's really very kind of you. I'm really very happy to be with you for your opportunity to explain this hypothesis to all your audience and more internationally. It's really very kind of you.
Thank you, Prof.
Thank you. See you. Bye-bye.